I'm Dr. Jeff Donovan. I want to thank you for taking the time to join me as we review 20 of the most influential studies of 2020. These are studies that have shaped my practice and some of the decisions that I make in the clinic every day with patients that are experiencing hair loss. If you're a physician, I hope that these studies will impact your practice and influence the decisions that you make in the care that you give your patients. If you're a patient, I hope that these studies will open up dialogue between you and your physician in terms of the treatments that you receive and how your hair conditions are managed. We'll start by talking about direct-acting anticoagulants. These are a group of medications which have been around for about 10 years. New studies suggest that they can be associated with a very small increased risk of hair loss. So it's important for us to know about them. I will talk about two studies related to COVID-19 infection. One study addressed hair shedding in patients with COVID-19. When do we expect hair loss to occur if it's going to occur in a patient with COVID-19? I'll also look at a study which has addressed the association between male pattern hair loss and severity of COVID-19 infection. Very fascinating studies that are very relevant to the current pandemic. I will go on to discuss 5 studies in alopecia areata, which is an autoimmune disease. We'll discuss the relationship between depression and alopecia areata and depression, this bidirectionality. We'll look at a study which addressed the changing epidemiology of alopecia areata. Is alopecia areata, in fact, becoming more prevalent? We'll look at studies addressing how should we most effectively use steroid injections in alopecia areata. What concentration is best and what are the side effects of the various concentrations? Then I'll look at a study looking at metabolic dysfunction, cardiac disease risks in patients with alopecia areata. A very large study suggested an association that was really not well appreciated before. Then we'll look at a study looking at the alopecia areata predictive score and how we can all use our dermatoscopes at 2 months after our treatments are started to predict how likely the patient will grow hair at month 6. So we'll look at the alopecia areata predictive score, what this means and how we can use it. We'll look at congenital triangular alopecia and a very interesting study looking at atypical patterns of congenital triangular alopecia. We usually associate this as a type of hair loss that affects the temples, but this was a study showing that it can affect other areas of the scalp as well. Then we'll look at androgenetic alopecia and a handful of studies that have been published this year, which are very important for us to know about. The first study is a study of low-dose oral minoxidil and how does 1 milligram compare to 5% lotion in women. A second study looking at a large number of patients using low-dose oral minoxidil, both men and women. What are the side effects that we should be aware of? What are the side effects of shedding? What are the side effects of swelling in the legs? What are the side effects of hair growth on the face and body? So a very large study of side effects in low-dose oral minoxidil. We'll look at 2 studies addressing the use of bicalutamide in female pattern hair loss. Bicalutamide is a prostate cancer medication, which is an anti-androgen, which can be used for treating female pattern hair loss. And we'll take a look at these 2 important studies. We'll take a look at a study looking at suicidality risk in users of finasteride. Then we'll go on to look at dutasteride and the use of dutasteride in males with androgenetic alopecia. From there, we'll look at scarring alopecia. We'll look at 5 studies which have been very important in how we manage patients with scarring alopecia. We'll look at a study of lichen planopilaris and the use of low-dose naltrexone in lichen planopilaris. Is low-dose naltrexone effective? A study which used low-dose naltrexone against placebo helps us answer that question. A study in New York looks at how common is frontal fibrosing alopecia and frontal fibrosing alopecia. Very important question that we didn't have good data for until this year. We'll look at frontal fibrosing alopecia and the use of dutasteride. How do we use this medication most effectively in FFA? Dutasteride is one of the most effective treatments, but should we be using it daily, 3 times a week, 5 times a week, or even every day? Then we'll look at the risk of allergic contact dermatitis in frontal fibrosing alopecia and lichen planopilaris. Do patients with these two conditions have an association between allergic contact dermatitis? So we'll review that literature, which is really, really important. And a study from Harvard has suggested that we perhaps need to be thinking about allergic contact dermatitis in patients. And finally, we'll talk about the use of topical 10% metformin in patients with central centrifugal cicatricial alopecia. So these are 20 very important studies which have influenced my practice, and I hope that you will enjoy these studies as I review them with you, and I hope that in some way they will be beneficial to you. And I thank you again for taking the time to watch. How did we come up with 20 studies that have shaped my clinical practice? Well, what I have done over the last years, I've carefully gone over studies that have been published in the medical literature, and it's been quite an impressive year of over 2,400 clinical research studies that have been published. And today we're going to focus on clinical research rather than some of the more basic laboratory research. I am a clinical dermatologist. I see clinical patients in the clinic, and every day I'm asked to make clinical decisions. And so it makes sense to look at the clinical research studies. And so from these 2,400 studies, I asked what studies are of interest, what studies are important, and what studies can impact practice. Not really a great question to limit studies, because from that, I only came up with a very small narrowing of studies. There were still 2,300 studies that were of great interest. And so I applied a principle called the ML principle, which stands for me like. And so applying the me like principle, we came up with 20 studies. So these are 20 studies that I like, 20 studies that I hope you'll like, 20 studies that are extremely important to anybody who is interested in the field of hair loss. And so we are going to review these studies together. I'm not going to review them in any order from 20 to 1 in terms of the most important or the least important. They're all very relevant. In fact, even studies that aren't presented here are really very relevant and very important to our field. But these are 20 studies that I think are extremely important. And we are going to start with a study which looked at safety. We're going to talk about safety quite a bit today because safety is key when it comes to treating hair loss. This was what we call a pharmacovigilance study. And if you don't know what pharmacovigilance is, I'm going to explain it to you. Pharmacovigilance is the science of detecting, assessing, understanding, and preventing adverse effects from drugs. Pharmacovigilance is a field that helps make us safer. It helps make the world safer in terms of drugs that are put on the market, drugs that are removed from the market if not safe. Pharmacovigilance is a field that seeks to make things safer for everybody. Every year, the FDA receives 350,000, 400,000 reports about drug side effects. Some of these come from physicians, some of them come from patients, some of them come from drug companies. And so the ability to monitor side effects is really, really important. And so in August, a pharmacovigilance study was published that I'd like to share with you today because I think it's important. It was a study by Chretien and colleagues looking at direct-acting oral anticoagulants and alopecia to go further with data mining in pharmacovigilance databases. So we're going to talk a little bit about these groups of drugs called direct-acting oral anticoagulants. So let's take a look. So direct-acting anticoagulants are a whole new group of anticoagulants, and many of you are probably familiar with warfarin, Coumadin, heparin. These have been around for a long time. But there's a whole new group of drugs that have entered the market about 10 years ago, and these are called direct-acting anticoagulants. And many over the last few years have wondered whether these are causing hair loss. They don't cause hair loss in everyone, but many are asking, are they causing hair loss in some people? And is there an increased risk of hair loss if you take these drugs? And so there is a huge database of patient safety information called the VIGI-based database. And many researchers get permission to look into this database to look at drug side effects. And so in these particular studies that I'm going to explain to you now, researchers use the VIGI-based database to ask if direct-acting anticoagulants were more likely to cause hair loss than other drugs. And so when you look into a database, you have a massive amount of information that gives you the chance to ask some good questions. It gives you a chance to ask, how often is a drug that you're interested in causing side effects? And how does that compare to drugs that you know don't cause that side effect? And so that's what researchers did. These researchers looked at these direct-acting anticoagulants, and they asked if these direct-acting anticoagulants are more likely to cause hair loss. You may be familiar with some of these direct-acting anticoagulants. Dabigatran was one of the first, entered the market about 10 years ago. But others have followed suit, and you may see some of these on your television advertised. They're very commonly prescribed drugs now for various reasons as blood thinners. And so these researchers asked if these direct-acting anticoagulants are causing hair loss. And what they found is that they have a slightly increased risk. And so on the left, we see the names of these direct-acting anticoagulants, and these researchers compared the chances of hair loss seen in these massive databases compared to amoxicillin, which we know probably doesn't cause hair loss, and desogestrel, which we know probably does cause hair loss in some people. And what these researchers found is that of these direct-acting anticoagulants, some of them were more likely to cause hair loss, including Xarelto, rivaroxaban, which had about a 2.69 increased chance of causing hair loss compared to amoxicillin. So these are important studies. They give us more evidence that patients who come to see us on these direct-acting anticoagulants who are reporting hair loss, that it's possible that these drugs are causing hair loss. And so we have to take a good history. We have to review the exact clinical situation, but these drugs are associated with an increased risk of hair loss. And so these pharmacovigilance studies are really, really important in our field to look at side effects of drugs. And these are what we call post-marketing pharmacovigilance studies. And they're called post-marketing studies because they're done after the drugs are approved. This study that I just reviewed with you, it just was published. And I mentioned that these anticoagulants have come to market for almost 10 years now, some of them. And so you've heard of phase 1, 2, and 3 clinical trials. These are the key clinical trials that are needed before a drug comes to market. Phase 4 clinical trials are the trials that are done after the drug is approved. And so these phase 4 clinical trials are really, really important to follow side effects after drugs are approved. And it's all of our responsibility to figure out if drugs that are on the market are causing side effects. So we're going to leave pharmacovigilance for now. We're going to talk about COVID-19. This is a study that I really enjoyed, published in November, looking at the SARS-CoV-2 virus and hair shedding. You're probably well aware now based on the news, perhaps from your practice, possibly from your own experiences, that the COVID-19 infection can lead to hair shedding. And so to date, there has been 68 million cases of COVID-19 as of this morning, and some 1.5 million deaths. And hair loss is a known side effect of COVID-19 infections. And so the authors of this study set out to look at the features of hair shedding. So what can we learn from this important study, which allows us to counsel our own patients? And so this study enrolled patients from March to August. These patients had a prior diagnosis of COVID-19, either from antibody testing or PCR diagnosis. And these patients all had hair shedding after their diagnosis. And hair shedding is known as telogen effluvium. So this study from November had 214 patients. The average age was 47. 78% of these patients were female. Many of them had fever, but 13% were asymptomatic. So they had hair shedding. They didn't know they had COVID-19, but the antibody or PCR tests proved it. Of these 214 patients, 77 needed medical treatment, 20% were in hospital, and almost 8% needed ICU admission. So these are the patients that were in the study. The key question for us as dermatologists, and the key question that I have wanted to know, is when after COVID-19 infection do patients expect shedding? And that answer is on average 57 days, 8 weeks after infection. And it has quite a range, ranging from 6 weeks to 10 weeks, but 57.1 days was the mean. And interestingly enough, another study also suggested that hair shedding occurred at a similar time point. In that study, 58 days. And so this seems to be the important number for us to remember. So why do we get shedding from COVID-19? Well, we don't understand all the reasons, but we know that fevers give shedding. We know that viral infections release massive amounts of inflammatory cytokines and chemicals throughout the body that can cause hairs to shed. Many of the drugs that patients receive in hospital, anticoagulants, corticosteroids, other medications can cause shedding. The stress of being sick can cause shedding. The changes in nutrition that occur can cause shedding. So there's really a whole lot of reasons for shedding to occur. The reason I like this study so much is it reminds us of a very important point, and that is 1 out of 10 patients in this study who had shedding didn't know they had COVID-19 originally. They had subclinical disease. And so when we see patients now in 2020, and when we see patients now in 2021 who come in with shedding, we have to think about stress and low iron and thyroid problems and crash diets, all these things that cause shedding. But we have to think about COVID-19. Some patients who are shedding may have had infection and were not aware of it. So really important studies to guide us as physicians. This was a study from April that I really liked by Goren and colleagues, a group from Spain who has published some really very interesting work. This is titled A Preliminary Observation, Male Pattern Hair Loss Among Hospitalized COVID-19 Patients in Spain, a potential clue to the role of androgens. So let's take a look. This was a very preliminary study which came out very early in the days of COVID-19. And why did this group focus on androgens and male balding? Well, we know that men are more affected by COVID-19 with severe disease than women. We know that children are less commonly affected by severe disease. And researchers have known that androgens play a key role in how the SARS-CoV-2 virus gets into the human body. And what I mean by that is shown in this diagram. This little green spherical cartoon is a schematic of the SARS-CoV-2 virus. This orange circle is an airway cell in the human body, something in our respiratory epithelium in our human body. And the way that the virus gets into the body is by attaching to an ACE2 receptor. And it does this with these viral spikes or these S proteins. And these S proteins are really important. The vaccines that are now coming out are all designed to help the body produce these S proteins so our immune system can attack the virus. But this TMPRSS2 is an enzyme that we have on our airway cells that helps activate this S protein that allows it to bind efficiently to the receptor to get into the body. And this TMPRSS2 enzyme is controlled by androgens. And so it's very clear that androgens have some important role. And so these researchers hypothesized that men may be more likely to be hospitalized compared to controls because of these factors. And so in the early days of COVID-19, they performed an observational study looking at how common male balding or androgenetic alopecia, AGA, was among hospitalized COVID-19 patients. This was a preliminary study. They wanted to perform these observations, get the data out, and get the world thinking about what this information means. And that's why I really congratulate these authors. This was 41 patients. They had a mean age of 58. 71% of these patients had advanced male balding, and 29% of these patients had no male balding. This is the scale that we use as physicians to classify balding. It goes from 1 to 7, with 1 being on the top left and 7 being on the bottom. It's called the Hamilton-Norwood scale. And so in this study, a large percentage of males with severe COVID-19 had more advanced patterns of balding. Here's a male, for example, with Hamilton-Norwood scale 6. And so these researchers told us that they saw 71% of their male patients with severe COVID-19 had advanced balding. And by calculating the frequency of advanced balding in the population in Spain and in the medical literature, they calculated that they would have expected around 31 to 53% of male to have advanced balding. So there were more males in hospital with advanced balding. And so this was their first tip-off that this may have something to do with severe COVID-19 infection. This was a preliminary study. The reason I like this study so much is it really encapsulates what science is all about. And that is, people make observations. They have a hypothesis. They think that this might represent something, and they go about testing it. And they publish their findings, and they ask the world to criticize their findings or corroborate their findings by doing more research. And certainly this study did have its own share of criticism, but that's okay. The authors went on to perform some additional really fascinating studies. This is a study here by the same authors. Instead of having 41 patients, they went on to study 175 patients, including some men and some female patients. And their conclusion was the same, and that is that patients with advanced androgenetic hair loss were more likely to have severe infection. 70% of the patients in their study with severe infections were male, 30% were women, emphasizing the shift and the increased likelihood of men being affected. But this also showed that women with advanced androgenetic alopecia were also more likely than expected to have severe COVID-19. The group didn't stop there, and this Spanish group kept going. And they collaborated with other groups around the world. And they asked a very important question in this September study. They asked, I wonder if anti-androgens might reduce the chances of males having severe infection. There's a group of medications that are commonly used for male balding. They go by names finasteride and dutasteride, and these are the anti-androgens. And so these researchers looked at 77 men in the hospital. They found a certain proportion of them were on anti-androgens, and a certain proportion of them were not. About 65 were not on anti-androgens. And what they found is that men who were using anti-androgen tablets were less likely to be admitted to the ICU. Again, emphasizing the possibility that this androgen pathway has a role in severe COVID-19 infections. This study was getting the interest of other research groups, and here's a study in the Journal of the American Academy of Dermatology last month by a group from the UK, and they too showed that male balding was a major risk factor for severe COVID-19. And so the reason I liked this initial study back in April is that it was small, but it was an important observation that people that were sick had more advanced male balding patterns, and the group knew that this study had its limitations, but they said, let's get this information out to the world and let's let others see what they think and reduplicate the studies and see the results they get. And that's why I really like this study. From COVID-19, we're going to shift our attention now to alopecia areata. Alopecia areata is an autoimmune disease. About 2% of the world has alopecia areata. Patients lose hair in various patterns. Some people lose hair in patches or small circles. Some people lose it at the back, which is called ophiasis. Some lose it all over their scalp. This was a study from May looking at the bidirectional association between alopecia areata and major depressive disorder. Really fascinating study, and I'd like to share what this is all about. There's a relationship between alopecia areata and depression. It's been controversial. It's been studied for a long, long time. Previous studies have taught us that psychological stress plays some role in alopecia. Doesn't play a role in everyone, but some patients, when they get extremely stressed, they find they get a patch of alopecia. That's very well known. And some studies have shown that there's this relationship between depression and alopecia areata. And so this research group wanted to look at this even further. They wanted to look at, does depression cause alopecia areata, or does it affect alopecia areata in some way? And does alopecia areata somehow affect depression in some way? And so what they did in this very, very large study from Taiwan is they looked at over 2,000 patients with alopecia. They looked at their siblings, their brothers and sisters, and they looked at controls, patients that did not have alopecia at all and were not related. And they asked, how many of these patients have depression? How many patients with alopecia areata have depression? How many siblings have depression? And what they found in this study was that patients with alopecia areata had an 8-fold increased risk of depression. But what was so interesting is that the siblings of these patients who did not have alopecia areata, they were simply related, they also had an increased risk of being diagnosed with depression compared to controls, suggesting there is this underlying genetic link that's causing depression. They went on to do the flip side of the investigation. They looked at patients who had major depression. They looked at their siblings, and then they looked at controls, and they asked, how many patients with depression have actually alopecia? And how many of the siblings have alopecia, and how many of the controls have alopecia? And what they found is that individuals with depression have about a 1.66-fold increased risk of having alopecia, and even their siblings had an increased risk of being diagnosed with alopecia. And so a really interesting study that teaches us that there's this link, this bidirectional link, that depression can impact alopecia and alopecia can impact depression. Here we're talking about the autoimmune disease alopecia areata. So a really fascinating study telling us there's this complex relationship between depression and autoimmunity. And we know that stress can affect many pathways in the body. Stress can affect the hypothalamic pituitary axis, or the so-called HPA axis. And we think that this affects a whole bunch of mediators that get produced in the body, cytokines and chemokines that ultimately affect what we call immune privilege, and that is the ability of the immune system to function properly and resist autoimmunity. And so a really interesting study, which will set the stage for further studies, but a fascinating study nevertheless. This was a study published in March, looking at the epidemiology of alopecia areata, ophiacis, totalis, and universalis. Ophiacis simply means hair loss at the back of the scalp. Totalis simply means total hair loss. And universalis simply means total body hair loss. And so this particular research group looked at all of the studies that have ever been published, looking at the frequency of alopecia areata and all these subtypes. And they identified 94 studies that had complete data. The researchers found that these advanced stages of alopecia, like alopecia ophiacis and totalis and universalis, are not that common, which we know, but it gave some quantitation to it, that it affects about 1 in 1,000 people. But what was so interesting in this study is that the prevalence of alopecia areata seems to be increasing over time. And I think this is really important because there are factors in our world that are influencing this particular autoimmune disease. We used to say, and sometimes I still say, that alopecia areata affects about 2% of the world. What we're learning now is that the number may be actually higher. Before the year 2000, alopecia appeared to affect about 1% of the world. In studies that looked at the frequency between 2000 and 2009, it appeared that it affected about 1.7% of the world. And in more recent studies, it suggests it's over 3%. So alopecia areata is becoming more common, and the reasons for this are not entirely clear. This was a study from April, which I particularly liked, and a study which is very relevant to dermatologists and physicians who treat alopecia areata. You may be aware that steroid injections are a very common treatment for alopecia areata. And this group performed a systematic review and meta-analysis looking at all the studies that had looked at steroid injections, looking at what is the best concentration that we should be treating our patients with. If you're not familiar with steroid injections, it's really a very important treatment for patients with patches of alopecia areata. This is a patient of mine with a patch of alopecia areata. He was treated with steroid injections, and 6 months later, he has hair growing in these areas. Steroid injections can be very effective for alopecia areata. We often use triamcinolone acetonide. There's other steroids that can be used, but these are steroids which can be injected into the scalp. It comes as 10 milligrams per mil, but we dilute it. And the key question is, how much should we be diluting it? Should we be diluting it in half to 5 milligrams per mil? Should we be not diluting it at all and just using 10 milligrams per mil? Or should we be diluting it even less? And so of all the studies that have been published, there were 7 studies which were particularly good that the authors found met their criteria, and it had 543 participants in those 7 studies. They looked at the frequency of hair regrowth with different concentrations of triamcinolone acetonide. And what the authors showed is that the 5 milligram per mil dose, where you dilute it in half, is pretty effective. About 80% of patients can be expected to have some good regrowth with that concentration. The key thing in this study is that these low doses of less than 5 milligrams per mil were still pretty effective. About 60% of patients still had some pretty good growth with these lower doses. And I'll tell you why I think this is important. Steroid injections come with a few side effects. And one of the side effects, which we are all aware of as dermatologists, and if you are performing steroid injections as well, you will know of this side effect, and that is atrophy. We hope that our steroid injections cause hairs to sprout up when we treat alopecia areata, but sometimes they can cause little indentations in the scalp, which we call atrophy. And sometimes what happens is we get hairs growing out of that little indentation. These little indentations improve over time, so fortunately they are temporary, but we want to limit this atrophy because patients don't like it. And what this study showed us is that the chances of atrophy is quite a bit lower at 5 milligrams per mil than 10 milligrams per mil. And 10 milligram per mil dosing, that is, if you don't dilute the triamcinolone acetonide, you can expect a 20% chance of getting these indentations in the scalps of your patients. And so a really important study. It gives us information that 5 milligrams per mil really is a much better dose to limit atrophy. But the reason I like this study so much is that it tells us that low doses of steroids can be effective. Even doses less than 5 milligrams per mil, even 2.5 or 3.3 milligrams per mil can still be expected to help about 60% of our patients. And so when I'm working with physicians that aren't used to doing steroid injections, I often say to them, start with 2.5 or 3. And if it doesn't work, if your patient doesn't grow hair, you can certainly go up. But you can expect a large proportion of your patients to grow hair with lower doses. But 5 milligrams per mil seems to be the dose that you want to stick to and not exceed if you want to limit the chances of atrophy in alopecia areata. Here's another fascinating study in alopecia areata from August, looking at the prevalence of cardiac and metabolic diseases in patients with alopecia areata. Cardiac and metabolic diseases in alopecia areata is an area that we do not pay much attention to in our review of patients and our counseling of patients. But I think with this study, I would encourage you to think about it. And we still don't know exactly how, but I'm going to explain the study, and you can make up your mind how you will change your counseling of patients. This was another massive study. This was a study of patients with alopecia areata that were found in this very large health database. And so they compared about 33,000 patients with alopecia areata to patients that did not have alopecia areata, some 57 million patients that don't have alopecia areata. And nowadays, with these large databases and these massive computer systems, it's fascinating how much we can do with this data. What they found in this study is that the chances of metabolic dysfunction and cardiac disease coronary artery disease was increased in patients with alopecia areata. This is a whole new understanding of what this means. The chances of high blood pressure or hypertension was increased 1.8 times compared to patients that don't have alopecia areata. High lipids or hypercholesterolemia was increased 3.5 times. Patients were more likely to be obese, have diabetes, have metabolic syndrome, have coronary artery disease, have atrial fibrillation or abnormal heart rhythms, and increased chances of stroke compared to controls. They didn't seem to have an increased risk of heart attacks or myocardial infarction in this study. And so this is a really, really important study because it tells us that we need to be thinking about heart disease, metabolic dysfunction, diabetes, cholesterol, in our patients with alopecia areata. This is new data. We don't know what to do with this yet. We don't know what screening tests to be doing in our patients, when to be doing it, how to counsel patients. But it's very important data, and further information will be coming in terms of what we do with this information now. How do we counsel an 11-year-old in my office who has alopecia areata? How do we counsel a 51-year-old and a 69-year-old based on this fascinating information? And so this study highlights the cardiovascular and metabolic disease in patients with alopecia areata. They're slight increases, so they're not marked increases, but they are slight increases, and they're important for us to consider. And we need to get other disciplines on board in terms of helping us know what to do with this information. And one more study in alopecia areata before we leave it. I love this study. It's a study from Poland looking at the alopecia areata predictive score, a new trichoscopy-based tool to predict treatment outcomes in patchy alopecia areata. It was published in March. Let me tell you what this study is all about. This is a patient with patchy alopecia areata. You've seen alopecia areata now in previous slides. These patients develop patches, sometimes in the front, in the back, maybe the eyebrow, it can be anywhere. And the key treatment is often corticosteroids, steroid creams, minoxidil. But this study looked at, are there any trichoscopic criteria that we can use when we examine the patient to predict if they're going to grow or not? And trichoscopes, in case you're not aware, are these handheld devices that are in some ways very fancy magnifiers that allow us to see the scalp up close. Here's two trichoscopes that I have in my office. And what this group wanted to know is, when we look at the scalp up close with these trichoscopes, are there any findings that we see where we can say to the patient, oh, I see this finding, it means you're going to grow your hair. Or if I see these findings, it means you're not going to grow your hair. That would be really powerful information if we could. And so they looked at 65 patients and they examined the scalp at the start of the study. And then they administered treatment. And then they looked at the scalp at month number 2. And then they looked at month number 6 to see if they grew hair or not. And what they found is that 26 patients were responders, they grew hair. And 38 patients were non-responders. They didn't grow hair, unfortunately. And so can we predict using our dermatoscope who's going to grow hair? Well, this group taught us that you can't at day 1. When you look with your fancy dermatoscopes, you can't gain any insight at day 1. So if you're sitting there with your dermatoscope on day 1 and you're asking what's going to happen at 6 months down the road, the answer is you have no idea. But if you look at month number 2, you can gain some pretty good insight into what's going to happen. And I've used this algorithm I'm about to tell you many times since this study was published, and I really like it. To look with your dermatoscope, you have to know 6 things that you're seeing. You need to know, when you look under the dermatoscope, what are upright regrowing hairs, what are pigtail hairs, what are exclamation mark hairs, tapered hairs, broken hairs, and black dots. Upright regrowing hairs are what it sounds like. They're little hairs that are upright and sprouting back up through the scalp. This means that hairs are coming back up. Pigtail hairs are exactly what it sounds like. They're hairs that are curled and coiled like pigtails. Tapered hairs are hairs that are thick at the top and really, really thin as they're about to enter the scalp. Exclamation mark hairs are hairs that are thick at the top and thin at the bottom as well, but they're really short. They look like an exclamation sign that you punctuate a sentence with. Broken hairs are hairs that are broken, snapped off, and black dots are little tiny dots that are black that mean hairs have snapped off at the surface. And so that's what you need to know when you look with your fancy dermatoscope. And if you see upright regrowing hairs or pigtail hairs, you add 1 point. If you see exclamation hairs, tapered hairs, or broken hairs, or black dots, you subtract 1 point. And then you tally up your score. And your score at the end tells you whether your patient's going to regrow hair or not. If you see both features and you don't have any negative features and your score is 2, there's a 98% chance that your patient's going to have hair at 6 months. If the score is 1, the chance goes down. And if you have a score of -4, your patient is not going to grow hair at 6 months. It's not worth waiting. It's worth changing up the treatment. So really powerful information. I really like this study, and I would encourage you to take a look at it if you haven't. I think it's a really fascinating study, how we can put the powers of observation to really good use. From alopecia areata, we're going to turn our attention to androgenetic alopecia. Androgenetic alopecia in males is called male balding. In women, it's called female pattern hair loss. In women, it often affects the central scalp. In men, it affects the temples and the crown. But then over time, the entire middle area can become affected. When you look up close, you see that the hairs are getting smaller. We call this miniaturization. There are many treatments for male balding and female hair loss. Topical minoxidil is FDA approved, Health Canada approved, approved around the world. There's anti-androgen tablets that are approved for men. But there's been a real surge in minoxidil pills at a very low dose. And so this study from January looked at minoxidil 1 milligram pills compared to 5% topical minoxidil for the treatment of female pattern hair loss. Now, minoxidil pills have been around a long time. They were used in the 1970s and 80s for treating blood pressure at doses of 20, 30, 40, 50 milligrams. And they had a lot of side effects, but they were kind of a last stage effort to try to get people's blood pressure down. And what was discovered is that about 80% of people were growing hair on the body, hair on the scalp. And that's how topical minoxidil came to be. Well, there's been an interest over the last 10 years, 15 years now, I suppose, in much thanks to Dr. Rod Sinclair from Australia looking at tiny doses of minoxidil. Can we use 1 milligram, a half a milligram, 0.2 milligrams? Can this do anything for patients with androgenetic alopecia? And the answer is yes. And so we're seeing a resurgence of interest in low-dose minoxidil. And so this study looked at 1 milligram versus 5 milligrams. It was a study of 52 female patients, and they compared one group receiving 1 milligram and one group receiving 5% once daily. And what they found is that there were similar outcomes at week number 24, at 6 months. Then they looked at side effects between these two groups. The chances of swelling in the feet or edema was about 4% in the 1 milligram group. Nobody applying topical minoxidil, 5%, had swelling in the feet. Hypertrichosis or excess hair occurred in about 27% of patients receiving 1 milligram and 4% of patients receiving 5%. So that's a really important finding, that hypertrichosis is common, and we need to counsel our female patients that hair growth can occur. It doesn't always cause people to stop the medication, but it certainly can be frightening if you're not aware of it. There was an increase in heart rate of 6 beats per minute above baseline. There was no increase in heart rate in the 5% group. That didn't carry any significance, but I think it's important to be aware of this. And the 5% lotion users had more scalp itching. They were using the lotion, not the foam. And so a really valuable study telling us that 1 milligram of minoxidil in women seems to be pretty equivalent to 5% topical once a day. I think this is really important data. to kind of give us some groundwork for what these doses all mean, because we really don't have a good guideline. And this is really the only study that's given us this information. We need more studies. This may not be the final number. This was another study in November looking at the adverse effects of low-dose oral minoxidil in 435 patients. So a very large study. And I really like this study. It's a study from Brazil looking at side effects. So they evaluated patients on low-dose oral minoxidil from January 2017 through May 2020. There were 669 patients that they had given low-dose oral minoxidil to. 435 agreed to get on the phone and talk about side effects. Women in the study had used minoxidil for an average of 7 months. Men had used it for an average of almost 6 months. This is a really important chart. What are the side effects of low-dose oral minoxidil? Most women in this study were using about a milligram, a half a milligram to 1 milligram. And most men in the study were using anywhere from about 1.5 to 5 milligrams. So men were using higher doses. But hypertrichosis, or excess of hair, was common. And again, women in this study were generally using 1 milligram or less. And so a little bit higher than some other studies, but really important. Headaches occurred in some patients, insomnia occurred in some patients. I really liked that statistic because there are patients over the last many, many years who have asked me, does minoxidil affect my sleep? And I have told them, I'm not sure, but gee, patients ask me that. This study sort of quantitated that, you know, maybe it does. There wasn't a control in this study to know, a placebo, but we need to keep that in mind, that insomnia may be an uncommon side effect of topical minoxidil. It certainly may be a side effect of oral minoxidil. Swelling in the feet was more common in women than in men. Dizziness could occur, heart palpitations, nightmares, edema, indigestion, and hair shedding. I draw your attention to hair shedding. This is an incredibly feared side effect of our patients. If they start oral minoxidil, are they going to get shedding? Fortunately, this side effect was limited to a very short period of time. So it didn't go on and on and on, a month or so. But we have to counsel our patients that they can expect hair shedding, 44% of women and 21% of men. And so really important data. I think this chart is really helpful as we sit down and we talk to our patients about what to expect. There are many reasons to consider oral minoxidil, and we want to do a good job counseling our patients. So from oral minoxidil, we're going to move to bicalutamide. If you haven't heard about bicalutamide, I assure you, you will hear about bicalutamide in the months and years ahead. It is very likely to become an increasingly common treatment for hair loss. It's an anti-androgen, and anti-androgens are used in treating hair loss. This was a study in women, and we use anti-androgens in women. We use spironolactone. Sometimes finasteride can be used, especially in postmenopausal women. There have been other anti-androgens as well. And these were two studies back to back in the November issue of the Journal of the American Academy of Dermatology. One by Ismail and colleagues, and one by Fernandez Nito and colleagues from Spain, looking at bicalutamide. For those of you who are not familiar, one of the trade names of bicalutamide is Casodex, if that helps orient you to this medication. These are approved for prostate cancer at 150 milligrams or so. Here we're using bicalutamide at really small doses. So Ismail and colleagues performed a retrospective review of some 316 patients who are using bicalutamide. These again are women with androgenetic alopecia. In the study by Ismail and colleagues, a large number of patients were also on spironolactone. A large number were also on minoxidil. There was only about 6 patients on bicalutamide alone. So we don't have a great understanding about bicalutamide alone, or what we call monotherapy, but nevertheless a really important study. Bicalutamide helped women improve their hair. It helped at 3 months. That's when the earliest signs could be seen, and it kept helping. Improvements occurred more at 6 months, more at a year, and up to 24 months. And so the results that a patient gets at 1 year is by no means the final result. There was a 3% increase in liver enzymes. They weren't serious in these patients. 3% of patients had edema, 2% of patients had GI side effects or gastrointestinal side effects. The liver enzymes in this study, in half of patients, they went back to normal, even when the drug was not stopped. In the other half of patients, they had to stop the medication, and the liver enzymes went back to normal. The group Fernandez-Nieto from Spain looked at 44 patients. They used slightly higher doses. They also showed a benefit of bicalutamide in treating female pattern hair loss. 11% of patients in this study had elevated liver enzymes. And so when we use bicalutamide, we need to follow liver enzymes a couple of months out. And at baseline, if you don't know what your patient's liver enzymes are. But these medications tend to be quite well tolerated. They can cause anti-androgen side effects, decreased libido, mood changes, irregular periods have been documented as well, so they are having anti-androgen side effects. From bicalutamide, we move to finasteride. Finasteride is an anti-androgen which is approved for male balding at a dose of 1 milligram. And what we are going to do is look at an important pharmacovigilance study, again, looking at finasteride. And it's a involved study, and I'd like you to walk you through it because I think it's important, and I think we all need to be aware of it if you're prescribing finasteride. The study was a study by Nguyen and colleagues in JAMA Dermatology last month, titled Investigation of Suicidality and Psychological Adverse Events in Patients Treated with Finasteride. So I remind you that we have these phases of the clinical trial, 1, 2, 3, and at end of phase 3, it's launched into the public. Phase 4 is where we do really important post-marketing studies to look at side effects that didn't appear in the clinical trials. And so every physician, every patient, everybody in the world needs to be on the outlook for side effects. And if they're occurring, we need to report it. And that's how these pharmacovigilance databases get established. So finasteride was approved in 1992 for the treatment of prostate enlargement at 5 milligrams. It was approved in 1997 for the treatment of male balding. And over the next many years, post-marketing type studies were done. And in 2011, the FDA released some information to the public saying that there have been reports of depression, self-harm, and possible suicidality. And we need to be aware of this, and we need to consider whether we counsel patients differently than we did in the 1990s when the drug was released. And certainly over the last few years, there have been new warnings that have been put on the labels of finasteride. And so when you open up the very long leaflet of finasteride in Canada, you will see that there are warnings that there may be a small number of patients that are affected by depression and a small increased risk of suicidality perhaps. And so it warns people that we need to be aware of this to study it more. And it warns patients that this could be a side effect. So let's talk about this particular study. So what about the relationship between finasteride and depression? Well, we know from published studies that finasteride can increase the risk of depression. And this particular risk of depression was added to the US label and the monograph about 10 years ago. But what about suicidality? but suicidality, we mean several things. We mean thoughts of suicide, not only completed suicide, but thoughts of suicide and attempted suicide. So there's been some studies in the medical literature looking at suicidality that I think it's important for us to be aware of. And I'd encourage you to retrieve these studies and make your decisions about the study design and how the studies were conducted. 2012 was a very important study which got people thinking about what are the risks and what does this information mean. Erwig published a study in the Journal of Clinical Psychiatry looking at depressive symptoms and suicidal thoughts among patients that had used finasteride and had stopped, but they still had side effects. And they showed there was an increased risk of suicidal thoughts in men that were using finasteride. Welk published a study a few years ago looking at suicidality and depression in men 66 and older. And what they found is there was no increased risk of suicide in these men, but there was an increased risk of self-harm. And Ali and colleagues published a study in 2015 looking at a very small number of patients, 39, indicating a small increased risk of suicidal ideation possibly in this study. And so what this study last month looked at was, what is the relationship between finasteride and suicidality and depression? And so they used, again, this huge database, this VIGI-based database, which is a WHO database of all these case reports of drug side effects. The VIGI-based database has been around since 1968. And as I mentioned, there's massive numbers of entries into this database every year for side effects. So what are the highlights of this study? Well, there were 356 suicidality cases and 2,926 psychological adverse events, depression and anxiety. The patients in this study were mostly men, and they were mostly young men, 18 to 44. And they identified what's called a signal for suicidality in finasteride users, which was not suicidal completion or suicide, but rather suicidal ideation. We're going to talk about that. This was a chart from their study, and they showed that amongst finasteride users and entries in this database, that suicidal ideation was increased compared to control groups some 3 to 4 times, but attempted suicide was not. What's interesting about this study is that this relationship was mainly at this low dose of 1 milligram. These findings were not present at 5 milligrams, which is the dose men use for prostate problems. And so in pharmacovigilance studies, a signal is a very important word. It means something. And we sort of know in the general public what a signal is. It's something that, flashes a light to us that a train is coming, or it sort of gives us an indication that we need to pay attention. And so in pharmacovigilance studies, a signal means that there's new information that has at least reasonable evidence. It doesn't prove it, but it means there's at least reasonable evidence that we should pay attention to it, that someone should delve into this further, and we should warn somebody. We should either warn patients, or we should warn health regulatory bodies, or someone should look further into this. And so they found some signals in this pharmacovigilance study with men who were balding. There was no signal in men that were using finasteride for prostate problems. So it seemed to be an issue with men using finasteride for balding. And it seemed to be a signal for young men, not older men, but young men who had this suicidal ideation. It wasn't to do with hair loss alone, because when they looked at people using minoxidil and people using dutasteride, there was no increased risk. So it wasn't the hair loss itself that seemed to do this. And this signal came after 2012. And so these concerns didn't exist before 2012 to the same level. It's not clear why, and there's many hypotheses for why. Perhaps it's these research studies that have been published, which made people more aware that if you're getting these feelings and thoughts, you should report it. that's subject to debate. But the main point of this study, and why I pointed out, is there are these signals in this pharmacovigilance study for suicidal ideation in young males. And so we need more studies, but it really highlights what these post-marketing studies are all about. It's up to all of us to observe, report, and leave it up to researchers who know how to work with very large numbers to figure out what it all means. But I think this is important. And certainly patients who are having emotional issues on finasteride at the 1 milligram dose, young men need to be removed from finasteride. I think that's really, really important, and get the appropriate counseling. So from finasteride, we're going to move to dutasteride. Dutasteride is another anti-androgen. It's not formally approved for male balding in North America, but it is an anti-androgen which is often used for male balding at doses of 0.5 milligrams. And my colleague Sergio Vano-Galvan from Spain published another nice study in dermatologic therapy in January, looking at the safety and effectiveness of oral dutasteride in male androgenetic alopecia. And so the purpose of this study was to look at how safe and how effective dutasteride is in the clinic. So the patients in this study were on average about 35. They ranged from quite young to quite old. They were using anywhere from 1 capsule of the 0.5 milligrams up to 7 capsules per week. And about 57% were using the dutasteride every day. 6.5% of patients had side effects. And 2.6% of patients needed to stop the drug because of side effects. They either had decreased libido, decreased sex drive, breast enlargement, which we call gynecomastia. They had mood changes like depression or erectile dysfunction. And what's really important is that no patient in Dr. Vano-Galvan's study who was using the low doses of dutasteride, which is 3 pills or less a week, had side effects. I think that's important. So of men in the study that were just using dutasteride monotherapy, nothing else, there was 42 of them. 90% had a marked improvement in their hair, and an improvement. 23, almost a quarter of the patients had a marked improvement in their hair. 9.5% of patients were stable, and no patient's hair loss got worse. With low-dose oral dutasteride, which again is 3 pills or less per week, 8 out of 12 patients improved. The results were not as good as using dutasteride daily, but there were no side effects reported in this study. So really important. Here's a very nice diagram from their paper, looking at a man using dutasteride 5 days per week with a very nice result with dutasteride. So the real important messages of this study are low-dose oral dutasteride is very much an option. That starting 0.5 milligram twice a week, 3 times a week, seeing where it takes a patient is certainly an option. Side effects were not observed in this study. Doesn't mean side effects don't exist in larger studies, but these side effects are less common than with daily use. And certainly more studies are needed. Dutasteride is becoming increasingly popular. And really some of the key questions that we need to answer as a medical society, a world medical society, is, does dutasteride truly have different side effects than finasteride? The 2 drugs are thought of as cousins. Finasteride inhibits 5-alpha reductase type 2, dutasteride inhibits 5-alpha reductase type 2 and type 1. We think of them as cousins, but they appear to possibly have different side effect profiles so far. But again, there's far more men in the world on finasteride than dutasteride. So really important study. From androgenetic alopecia, we're going to move to a condition which some of us may not be quite as familiar about. It's called congenital triangular alopecia. It's a study published this year that I thought was very fascinating. Starace and colleagues in October published this study of atypical presentations of congenital triangular alopecia. So what is congenital triangular alopecia? Well, it is a condition that appears in the first years of life, usually age 3 or 4 or 5, where patients lose hair at the sides, often in the temples here, and it's shaped like a triangle with the point pointed up to the top of the scalp. And this particular male patient has had this area of hair loss since grade school. And that's what congenital triangular alopecia is. And when dermatologists do exams, they are always tested on congenital triangular alopecia. We don't know how common it really is. There's been less than 150 reports in the literature, but maybe 0.1% of the world has it. It has this triangular shaped area. When you look with your trichoscope, you see these thin hairs, vellus hairs, and then eventually they disappear. There's no signs of alopecia areata that can look identical, and it doesn't grow. It stays the same over time, no matter what you do to it. And so what this study suggested is that it's not always in the temples. And there's been other studies in the past that suggested that as well. But this was a study of 78 patients with congenital triangular alopecia, 10 of which had an atypical location. In 5, the location was in the back, or the occipital region of the scalp, which is the area behind the scalp, the parietal scalp or the sides, and 1 patient in the vertex. And so here's a patient with what was presumed to be congenital triangular alopecia with a triangular or lancet-shaped area of hair loss in the back. It doesn't grow over time, and the dermoscopy shows these vellus-like hairs. And so this is an important study because it reminds us that we need to really study this entity further and get a sense of this entity. It's easy to misdiagnose as alopecia areata, and certainly if you misdiagnose it as alopecia areata, you run the risk of creating unnecessary worry. And you also run the risk of using more and more treatments to try to get the hair growing, perhaps stronger and stronger treatments with side effects when hair does not usually grow in congenital triangular alopecia. And so I really liked that study. I thought it was really novel, and it sets the stage for more studies of this condition. So we're going to move to scarring alopecia, and then we'll open for some questions. For those of you who are not familiar with what scarring alopecia is, it's a group of hair loss conditions that are associated with scarring. The image on the left shows an up-close image of the scalp with all these little yellow dots or hair follicle openings. This is where the hair comes out. Some of them aren't there. This happens to be alopecia areata. But when you look at this image on the right, this is scarring alopecia. You don't see the little openings anymore. They are scarred over, and this is very smooth. That's what scarring alopecia can do if it's not treated appropriately. There's many scarring alopecias: lichen planopilaris, frontal fibrosing alopecia, folliculitis decalvans, central centrifugal cicatricial alopecia. They generally have very long names. But we're going to talk about lichen planopilaris first. Lichen planopilaris is a scarring alopecia which is seen very frequently in a hair loss clinic. It causes hair to be lost, often in the center of the scalp, but it can be anywhere. It can be diffuse. It can be on the arms and the legs, the eyebrows, and it causes patients to be very itchy and have burning and shedding in the scalp. And so this was a study from June that I really liked, looking at the efficacy and safety of low-dose naltrexone versus placebo in patients with lichen planopilaris. So what is low-dose naltrexone? Well, what is naltrexone? Well, naltrexone was approved in 1984 for the treatment of opioid addiction. So addiction to opioids at a dose of 50 milligram. And so these 50 milligram pills were produced, and it's still a treatment on the market. And so if you go into a pharmacy and ask for a naltrexone tablet, they'll give you a 50 milligram pill. A number of studies over the last 10, 15, 20 years have asked the question, what about really low doses? And low doses have been suggested to have a benefit in autoimmune diseases like multiple sclerosis, like inflammatory bowel disease. And in 2017, Strazula and colleagues from New York asked the question, can it be helpful in lichen planopilaris? And so they performed a study of 4 patients that had been using it. These patients were also on doxycycline and pioglitazone and topical tacrolimus, other treatments, but they found these patients improved. And so Lejvardi and colleagues in the Journal of Dermatologic Treatment in 2020 set out to look at more patients and to do a randomized controlled trial. So there was 34 patients in their study, and they were divided into 2 groups. One group got clobetasol, topical lotion, which is a steroid, and low-dose naltrexone. The other group got clobetasol and a placebo. Now, the authors of this study felt it was unethical just to give a placebo because if you don't treat lichen planopilaris, the hair will worsen over time. And so it's not ethical just to give a placebo. And that's why they gave clobetasol in both groups. And then they evaluated the disease. They evaluated the disease at 2-month intervals by what's called the lichen planopilaris activity index, or the LPPAI. And what they found is that in groups that were treated with clobetasol and low-dose naltrexone, that the activity, the LPPAI, decreased 25.6%. In those that were using clobetasol and the placebo pill, the LPP did decrease 22.8%. But this was found by the statistics, the fancy statistical methods, to really not be a difference. It was statistically not significant. And so it appeared that clobetasol and low-dose naltrexone had the same outcome as clobetasol and placebo. And so really important study, and it teaches us we need to know more about low-dose naltrexone. We need more studies. Who exactly does it help? Does it help when a patient is on other treatments? If they're on doxycycline, pioglitazone, topicals, is it more likely to help if they're just on something like clobetasol? In this study, it appeared that low-dose naltrexone had an impact on redness in the scalp. It didn't affect the actual activity of the disease, but it impacted redness. So this means we need to study this aspect more. But it certainly is an important study because it tells us that if we promise all of our patients that they will improve on low-dose naltrexone, we are going to be wrong some percentage of the time. This is a study from October looking at the prevalence estimates for lichen planopilaris and frontal fibrosing alopecia. How common are lichen planopilaris and frontal fibrosing alopecia? Up to now, we don't really know. The only thing we ever quote is how often they're seen in the clinic. But how common are they out there in the real world? That's what the authors set out to do. And so they looked back at the electronic health records from 2 hospitals in New York Presbyterian and Columbia Doctors, for the ICD-10 code L66.1, which tells the researchers that these patients likely had LPP or frontal fibrosing alopecia. Then they went into the charts to make sure that they were correct. And they looked at all patients in the health system without LPP or FFA as controls. They identified 381 patients of these 1 million patients that had this particular diagnostic code. And what this translated into is that lichen planopilaris possibly occurs in 1 out of every 5,882 people. And FFA occurs in 1 out of every 6,666. I think this is really an important study because it gives us some idea of how common these diseases are. And I think it's valuable. We didn't actually know this information with any great certainty. What I find fascinating about this study is that I do think that LPP is even more common than 1 in 5,882. This particular group did a wonderful study, and so that's what they pulled from the charts. But what this tells me is there's probably a lot of people walking around with lichen planopilaris and do not know it. So that's food for thought for further studies. So we need this information. We need to know how common diseases are, and we need to know how it changes over time. We're seeing alopecia areata change in frequency over time. We need to know the baseline rate of these diseases. So from LPP, we're going to move to frontal fibrosing alopecia. Frontal fibrosing alopecia was unheard of before 1994, but it's much more common now, and we don't know why. Frontal fibrosing alopecia is a condition which is a scarring alopecia. It causes hair loss in the frontal scalp. This is the boundary between where the hairline used to be in this female patient. This is the unaffected skin, and this is hair that has now been lost. It affects the sides of the scalp. It affects the eyebrows, eyelashes, body hair. It affects the skin. It increases the chances of thyroid dysfunction, androgen deficiency, possibly early menopause. So it's a complex hormonal and autoimmune condition. But this study in October looked at the effectiveness of dutasteride in frontal fibrosing alopecia. And they set out to look at the most effective dose. What's been very clear over the last few years is that this tablet dutasteride, which we often use for male balding, as you saw a few moments ago, has emerged as one of the most effective treatments for frontal fibrosing alopecia. What we didn't know is how many times a week should we be using it. Some groups have suggested that we should just use it 3 times a week. The drug has a really long half-life. When you use it, it stays in the body a long time. You don't need more than 3 times a week. And so this group set out to look at the benefits of different dosing. So it was a retrospective study of 224 patients. The follow-up was 2 years. And patients in this study were using topical therapies plus 1 of the following: finasteride or dutasteride or doxycycline or hydroxychloroquine or isotretinoin. And dermatologists were asked to figure out if the hairline was moving back or staying the same. And that's how they figured out if the treatment was working. And what was discovered in this study was that dutasteride was more effective than other therapies for stopping hair loss. 61% of patients with dutasteride had their disease stopped, compared with 35% of patients in the other combined group, doxycycline, hydroxychloroquine, isotretinoin. And what's really important from this study is that dutasteride 5 to 7 times a week was more effective than other dosing strategies. So it doesn't mean that dutasteride 3 times a week is not effective, and it doesn't mean that your patient shouldn't be on 3 times a week. It might be the best dose for them for managing side effects and other things. But this study taught us that dutasteride 5, 6, and 7 times a week is more effective than using it 3 times a week. And I think this is really important information that we all need to be aware of. Dutasteride still sits on the top of the list as the most effective treatment. And we can now clarify that to say dutasteride 5 to 7 times a week sits at the top of the list. A study from August looked at allergies in patients with lichen planopilaris. As you know now, the search is underway to find out what causes frontal fibrosing alopecia. It was unheard of before 1994, so what is causing it? Some studies have suggested that allergens could be involved. There's been studies that have been published in the medical literature. And so this study sought to look at whether patients with frontal fibrosing alopecia and lichen planopilaris have specific things that they're allergic to. If you're not familiar with patch testing, this is a patient undergoing patch testing. It's where we put pure chemicals on the back of a person. We leave them there for a couple of days. Then we remove those patches and we see if the patient has developed an allergic reaction in the skin. This is very different than prick testing that you might do at an allergy office to see if you're allergic to your cat or dust mites. So this was an 18-month study, January 2018 to June 2019, with 42 patients. And they found in this study that patients with lichen planopilaris FFA did have specific allergens. 61% of the patients in this study had LPP, a quarter of them had FFA, and 11.9 had both. If an allergen was found, the patients were asked to go through all their products, their shampoos, their lotions, their creams, everything they can find in their household, at work, in their car, and not use it. And then see if 3 months later they were feeling better, if their scalp was better, if their scalp was less red. So the most common allergens in this study were phthalates, linalool, and fragrance. Phthalates are really common. They are things that kill bacteria and fungi and yeast, and they're in all sorts of creams and lotions. Linalool is a fragrance. It's in all sorts of cleansers and other topical products. Fragrance mixes abound everywhere in our world. It's what makes things smell good. And so what this group, Dr. Senna's group from Harvard, found is that the frequency of positive reactions was different in LPP than we expected. There were more patients with LPP reacting to fragrance mix than we would expect in the general population. There were more patients reacting to MCI-MI, which is a preservative, than we would have predicted in the general population. This part I really liked. 20 patients participated in a follow-up where they came back to clinic, they filled out a survey, and the dermatologist looked at the scalp. 58% of patients reported that when they avoided the allergen that they were told they were allergic to, they had decreased scalp itching. 77 felt their scalp was less red, and 70% of patients actually had less redness on examination by the dermatologist. This is a preliminary study. Only 41 patients, small study. We still don't know the role of allergens. Another study by a Polish group, very nice study as well, found completely different allergens. And so we don't know what to do with this information yet, but this was certainly an interesting test, interesting study that perhaps we should be considering sending some of our patients for patch testing. Who should we be sending? If we have hundreds of patients with lichen planopilaris and FFA, should they all be going to patch testing? We don't know. This is a preliminary result. But what we do have is low allergen shampoos that people can buy from the internet and get them shipped to their homes. And we can ask patients to simplify their topical products. If a patient is using 14 products, shampoos, lotions, cleansers, conditioners, hairsprays, hair gels, hair mousse, perhaps we can limit that to 6 and 5 and 4 products, and maybe this will have an impact on the disease. I think it's a really important study. Finally, study number 20 is a study of another scarring alopecia called central centrifugal cicatricial alopecia. And number 20 by no means reflects its position in this. Simply somebody has to be 20. CCCA, if you don't know, is a scarring alopecia that affects women with afro-textured hair, and it causes scarring alopecia in the central scalp, and it moves outwards over time, and it's much more common than we realize, so it's tremendously underdiagnosed. And so this was a study in JAAD Case Reports from February, which looked at a novel treatment for CCCA. CCCA is typically treated with topical steroids like clobetasol, oral doxycycline, steroid injections, topical tacrolimus. This study looked at the diabetes medication metformin, and not taking metformin by mouth, but crushing it up into a cream. You've probably heard about metformin. It's one of the more common drugs in the United States and around the world. And it probably does more than just controls blood pressure. It may have an impact on the immune system. It may have an effect on inflammation. It may affect gut health, and it may affect scarring. And so it's been studied in what we call fibroproliferative diseases, diseases that cause scarring. The metformin increases this molecule signaling pathway activated protein kinase, AMPK, and this particular signaling pathway is decreased in CCCA, so it makes sense that it could help. So this is a photo from their study in a patient that had used topical 10% metformin for 6 months. They had previously been on topical clobetasol, steroid injections, minoxidil, and when they used topical metformin 10%, they had a very nice result. The other patient in this study, there was 2 total. She used topical metformin along with other treatments as well and had an improvement in her hair density. So a really interesting study. This was 10% metformin made up in lipoderm cream, and so it may be an option for CCCA. This is 2 patients, but a very exciting study. There were no adverse effects with this topical metformin, and so that's really exciting as well. So hair research has really flourished in 2020. It's hard to pick 20 studies, but I used the me-like principle to bring 20 studies to the board tonight, and I hope that they've been insightful for you and will benefit you in some way. And these studies have caused new insights into what causes these diseases, the best treatments, and these pharmacovigilance studies with finasteride and the direct-acting anticoagulants have shown us the power of these massive databases and how we can use tens and hundreds of thousands and even millions of patients to harness data quickly to get some understanding about post-marketing surveillance. So I want to thank you again for taking the time to review these 20 very important studies that have been published in 2020. I hope that these studies will be of benefit to you, whether you're a physician or a patient. I know that many tuning in today are from different time zones across the world, and so I very much appreciate you taking the time to join me, and I look forward to reviewing important studies again in the very near future. Thank you.